Hello, everyone. My name is Claire Leather. I am the Public Reporting Program Manager at the Center for Improving Value in Healthcare, and I'm joined today by Sharon Ullery, Research Analyst at HSRI, our data vendor, and our partner in creating the Provider Payment Tool, which is what we're going to talk about today. Before we get into the tool, I want to just briefly touch on the data source, which is the Colorado All Payers Claims Database. This database contains over 1 billion claims going back all the way to 2013, with over 70% of the covered lives in the state of Colorado for medical claims, which includes 40 commercial payers, Medicaid, and Medicare, so a very robust APCD. So excited to talk to you all today about the Provider Payment Tool, some background about the tool. The impetus of this report was a piece of legislation, Senate Bill 22068. The bill requested that CIVHC, as the administrator of the Colorado APCD, provide price information for Colorado providers based on CPT and HCPS codes for medical, surgical, and diagnostic services. This is a unique, one-of-a-kind tool given the amount of data that is displayed, which we will get into shortly. So let's dive deeper into what is included in the tool. The legislation outlines a couple of key things for the tool to show. One is codes and years. So the tool has all current codes with sufficient volume, so that looks like 30 or more claims statewide for us, from 2018 all the way to 2021. We also show the codes via payer type, so breakouts for commercial, Medicare, Medicaid, Medicare fee-for-service. And we also display the payments as a total allowed amounts. So total allowed amounts is a payer and patient liability combined at the 20th, 50th, 60th, and 75th percentile. And we also include averages. And last but not least, we have a special section for anesthesiology calculations because anesthesiology payments are reimbursed very differently from the other kinds of providers. And we can get into that when we show you the tool.
So let's do a brief demo of the tool. So we go to our website, civhc.org, go to Get Data, Public Data, Focus Area, and all the way down to the Provider Payment Tool. So this is what the web page looks like. We have a little overview of some of the information I shared with you earlier. Scrolling down a bit more, we have some key considerations about some of the limitations of the report. And as you scroll down, you get the tool itself. So I'm going to walk you through some of the basics of the tool. First thing you can do is select the year you're interested in. From there, you can select the payer type. From there, we look at place of service. So it can be inpatient, hospital setting, or outpatient. And then here's the geography type. So we have 3 different geography types to sort of capture the diversity of the regions in Colorado. We have it at the county level, at the Division of Insurance level, which is sort of the regulatory level. And then we have the statewide level. So I'm going to select county. It's going to turn blank, but don't be worried. Here, you can select the actual county from geography. And then this is a list of provider type or setting. Sharon will go a little bit into this, the categorization of this, but you have a lot of different places, a lot of different categories to choose from here. So I'm going to stick to specialists and osteopathic providers. And here you can see all the CPT codes that pop up. Now, if you have a specific CPT code that you can type it in here and that CPT code will populate, which is very nice. And then you have instructions. Just in case you forget all of this, there's an instruction to guide you through the report. Second tab is the anesthesia piece. So this is the most complicated part of the report of the tool. It's because anesthesia is reimbursed a little differently. So there's this fancy calculation that has to happen. So this tab does the calculation for you. So again, you have the same filters that I just went over, but this orange ribbon has a couple of new items for you to select. So choosing the code, the anesthesia code description here. Selecting that, the physical status. So physical status is the physical status of the patient. So here's a little cheat sheet that folks can use. So you select that. Then the price modifier. So the price modifier for anesthesia is who is performing the anesthesia procedure. So you select that. And then how long is the patient under? So this is where you select the time units. Every unit is 15 minutes. So if you wanted an hour, you would put in 4, and then it would come up with a reimbursement rate for you. The conversion factor comes from the Colorado APCD based on the percentiles that we've talked about, but the reimbursement rate is calculated uniquely every time you put in these inputs. So pretty complicated. Sharon will go into a little bit more about the methodology in a second.
So how can this tool be used? There's a myriad of ways. First, for employers, self-insured employers can understand how their payments are versus statewide county and DOI payments. For the fully insured employers, they can look at pointing their employees to the tool if there are questions on bills or understanding what a reasonable cost for a procedure is upfront. For payers and providers, it can benchmark how their payments compare to their peers. For policymakers, it can identify variations in payments for procedures across the state. So as I mentioned before, Colorado is geographically diverse. We have urban and rural communities, and sometimes based on where you live, you might pay a different price for a procedure. And then lastly, for consumers, they can use this tool to understand what common or reasonable prices for a provider bill in their community would be. Now, I'm done with my portion. I'm going to pass the baton off to Sharon so she can talk a bit more about the methodology behind the report.
Thank you so much for that summary, Claire. So to sort of sum up what Claire has been saying from a methodological standpoint, this tool looks at fee-for-service payments. It looks at allowed amounts. It looks at professional claims only, and it looks at in-network claims only. There's a small side note there that Medicare fee-for-service doesn't submit data in a way where we can distinguish in-network and out-of-network claims, but Medicare fee-for-service so rarely pays out-of-network claims that we felt confident just including all of those as in-network in our data set. The biggest methodological challenge was just the volume of codes. Thousands of codes with then a bunch of different breakdowns. And sort of the flip side of that is that there are a lot of procedures that are rare enough that we didn't have good data to present. So we decided on a threshold of 30 or more claims statewide and said you have to have at least 30 claims within one set of parameters to publish that data. And that allows us to have a sense of reliability in the data, that if you see differences from year to year or location to location, that is most likely due to underlying trends and not to anomalies in the data. We did limit 2 codes that were in effect in 2021, excluding deprecated codes. And we had to make a decision about how to determine costs based on a per unit cost or the total for a procedure. So we went to the data for that. We looked and said if 3% or more of the claims have more than 1 unit submitted, then we'll assume that this is reimbursed per unit. And if it's less than that, we'll figure those might be data errors and calculate it on a per code basis. Another methodological challenge we had is that the legislation asked us to show costs based on provider type. Unfortunately, the way that claims are billed, the provider information is often for the organization that a provider is part of rather than for the individual. So sometimes instead of saying this claim was billed by a behavioral health specialist, it said this claim was billed at a community health clinic. So we ended up on the tool with a combined category for provider type and setting based on whatever was on the bill. We did opt for the most general categories that were still useful to users in order to avoid suppressing any claims that we didn't have to due to carving it up into smaller volumes. There were 2 specific categories of codes that were particularly challenging due to data issues. Medical transportation claims are a hot topic in surprise billing, and part of that is because the clear majority of ambulance claims, at least in Colorado, are out of network. Since this tool is about in-network costs, that means that most ambulance claims are outside the parameters for this tool, and so we end up with these reported costs based on a pretty small percentage of what's actually going on in the universe of medical transit. So we did include those procedure codes, but they should definitely be interpreted with that context and with a degree of caution. Another sort of specific area is anesthesia, which is also a hot topic with surprise billing. And the reason this is challenging, there's some of that same issue of a lot of anesthesia is billed out of network. And the other piece is that billing is, and reimbursement is calculated very differently for anesthesia compared to a lot of other procedure types. But sort of on the plus side, the way it's calculated, we were able to put all anesthesia codes together to get a large enough group of information. And then we used the standard reimbursement formula. We sort of reverse engineered it into estimating a reimbursement rate for anesthesia in general, and put on the website a formula that allows you to look at what that would mean for different types of anesthesia under different conditions. Another challenge with the anesthesia data is that units are not always properly submitted, and so we did a fair bit of cleaning trying to understand what was meant, and where we just didn't have units at all, we sometimes had to throw that out, but often we did some sort of statistical wizardry to fill in best guesses. And I think that wraps it up for us. Thank you very much.